About inflammatory membranes, you see, I'm not very sure whether we should be doing Lucentis because, especially idiopathic toxo, I'm very much scared to give this injection because the injection per se induce some kind of inflammation unless and until the membrane is recurrent. It's the only time I've done Lucentis in a patient is that patient has to repeatedly be injected. By and large, I treat them with steroids and response is pretty good.
If you see both the children that I have depicted, both were one-eyed. The other one, the macula is gone already with a large toxoplasma scar there. And the patient definitely does show a rapid deterioration. Patient has been nearly 5 to 6 months on an anti-toxoplasma treatment. It's not that we have not tried that. And I would agree with you that we would probably be a little careful because even one of our cases that I showed, there is some amount of retinal thinning which has happened following Lucentis also. So this is a grey area which we really need to think on as to what is the ideal way of approaching it.
So grey area is because, once you have first line of treatment will be anti-toxoplasma treatment.
Anti-toxoplasma treatment was different.
If it does not work,
yes,
then you can think of other modalities of treatment.
Definitely.
No, but for a CNV, even if it's secondary to toxo, it's not going to respond to. It's not going to respond to anti-toxo.
Some of them, some inflammatory membranes do respond to anti-inflammatory treatment.
No, a lot of these inflammatory membranes,
yes.
you see, CNV does not necessarily mean, you see steroids, what I'm saying is, based on personal experience,
yes.
I've not reviewed
No, definitely personal experience mine is also that they do respond to
steroids. And if, you see, only time I've given is, suppose after 2-3 injections, it keeps bothering me
yes.
and patients come, then I will consider. But as a first line, I will with it.
As a first line, definitely anti-inflammatory and like yes. Toxoplasma, the pathology is toxoplasma, start a toxoplasma treatment which has to be continued after 6 weeks or so, even after the injection has been given. But if they are not responding, as I said, they are one-eyed, then you need to do something. Young patient losing vision, reading, writing vision, school going becomes an issue. All those things, correct. Whatever has to be done under the cover of all anti-inflammatory therapy.
Very nicely said. Thank you.
Voting हो गया.
Yes, sir. अभी diabetic session चल रही है. Malika, go ahead. Okay. Thank you, Dr. Malika, for having me here in this very interesting session on macular disorder. I'll try to cover a burning topic that how to arrive at the end point. All of you and all of us also keep injecting Avastin, Lucentis anytime a patient of CNVM comes. These are my financial disclosure that I am consultant to Novartis. We all understand, all of us also will have the same stage. Sometimes I jokingly keep telling Dr. Tiwari, have a prophylactic Lucentis in your eye. Management of AMD has gone through various phases, and this chart borrowed from Novartis tells us that today we are not looking at stabilization or loss. We or patients are aware that they are hoping for some gain of vision. Patient by and large does not understand disease in our subgroup population. Ultimately they want some gain. Thermal lasers are indicated in very few percentage of patients. Like when this is a miles away, CNVM where which has responded very nicely. This patient actually has injured streaks, if you notice very carefully here. The other eye lost because of scar. At that time we did not have these injections, so I lasered the whole papillary macular bundle. But believe me, this treatment is still finite. This lady still has 6/12 vision after long follow-up also. Subfoveal, you can't do laser because of obvious fall of vision. After that came this era of cold lasers, PDT, but PDT, I think we have been discussing indications. Primarily, it is structural, CNVM, meaning there were well-formed membranes. We prefer, like in IPCV or RAB, we do prefer PDTs. And that also in combination. PDT alone has limited indication because PDT itself causes damage to the choroid and can have decrease in vision also. This slide from Dr. Dinesh Talwar's study of pre and post PDT. One PDT induces very nice regression. So what is the end point of regression is that end point does not mean that OCT has come down. That's a response. But end point could be, from angiography. Angiography truly shows that this CNVM has regressed. This era of VEGF inhibitors came after that, and this multitude of studies have been done just to impress that Lucentis does work. And these wonder drugs, are the main thing everybody wants to give for any disease, like you just heard, whatever type of membrane. The key question is which injection and what is the endpoint. We have all seen CAT study, IVAN study. So where are we as of today? Lucentis versus Avastin, with CAT and IVAN generally showing similar kind of efficacy, although there is a tilt towards Lucentis even in these. So driving factors, is it only the cost which we are bothered, because a lot of patients keep asking, especially once you have to give repeated injections. Lucentis price has been slashed from say 71,000 to 58, now to nearly 15,000 rupees. Cost does matter in our population. This is the study which shows that monthly bevacizumab is non-inferior to monthly Lucentis. So again, where are we? From the point of view of safety, Lucentis does, I think, score over Avastin. From the point of view molecule per se, but safety with respect to preparation, again Lucentis overscores. Because Lucentis is meant for one patient use by and large, whereas Avastin we have multiple, picks we keep giving. And there's no uniform method. Somebody will, have a spirit swab over it and then keep withdrawing every day. And then somebody will keep it for 2 weeks, 4 weeks, 1 month. I'm not sure. Malika, how much do you use? If you open an Avastin vial, suppose you open on a Saturday, for how long will you keep using Avastin?
The way I do it is we send it for aliquoting. So, yeah.
So that is one method of aliquoting. Dinesh?
So we open the vial, then we keep the vial for a maximum of 1 week. And within that week, each time it is used by first cleaning the vial stopper with the spirit. And then after the withdrawal of the drug, then again it is cleaned on both sides and then closed and put back in the fridge. And then each time it's opened, the same procedure is followed.
Why 1 week?
Because basically 1 week was the sort of absolute minimum needed to make it a viable proposition. Right?
That is economics.
It's the economics of the thing.
Economics is there.
Yes.
What's the viability?
Yes,
No, viability may be for longer, but we didn't want to take
What
a
is the
chance.
shelf life of
The
Avastin?
longer, no, okay, let me tell you that you can keep the vial for 3 months, but the question is, the longer you keep the vial, the more you increase the risk of a problem.
My job has been done. My job has
So
been
that
done.
is why to minimize the amount. Right? Ideal would be to keep it for 1 day.
No. Huh?
Ideal would be to give it in 1 day and throw it.
Not 1 day.
You can take it in one go and throw it.
Yes.
I think we'll go ahead because my job has been done.
Yes.
This is what I wanted, that there's no uniform method. So I will not provoke other people, Vinik or other people to opine over this. There are various methods. And believe me, sometimes, not with everybody, people like Dinesh may be very cautious, a lot of people may not be. There could be some compromise. You see, the fear is not for the molecule Avastin, like Dr. Azad was trying to say. Avastin will still, I think, remain functional for a couple of weeks. But it is the method of withdrawing or preparation of Avastin which is. So a lot of cluster endophthalmitis have been reported. 5-7 epidemics have been reported all across because of the problem of aliquoting. So here is when I say this Lucentis is the winner, I don't have to bother. Today, once the price has been slashed, I don't have to convince too much to the patient that prefer an injection which is only for you, not for sharing basis. So efficacy, safety, costing also is now not a much issue. So what is the endpoint? Is it actually ill-defined? I will not again raise the controversy. I will not ask Dr. Praveen or others. What is the endpoint? It is actually ill-defined. Is it dry OCT? Is it absence of hemorrhages? Is it cessation of neovascular activity or regression of CNVM? I think it's the combination of all. This has to be achieved in all. So you require a combination of clinical examination, angiography and OCT, and not just OCT. I'll take 3 minutes more. Today, internal injections have become main source of income. People keep giving injection for any macular lesion, and there's a rain of Avastin everywhere. And why I've drawn this cycle here is Avastin camps are being held everywhere. and Avastin is being transported from one center to the other center because, like the patients are not enough. Okay, wahan le jao Avastin. Method of preparation is again, Avastin is kept for weeks and months, and for many, believe me, for many, any regime is okay. Sad part is sometimes science takes a back seat. Money matters more. Problem is further compounded. Believe me, if one patient, my patient, I give him one injection, if he benefits, he virtually becomes my slave. Whatever I tell him, he'll follow. So if patient benefits the first injection or second injection, then he becomes very cooperative and he is willing to do whatever you say. Believe me, most of us don't understand what is ARMD. We keep treating. We do understand that VEGF has a role to play, and hence the role of all the VEGF inhibitors. We'll not go into this future of anti-VEGFs. Drops, if they come, squalene, this would be transformational. Similarly, Fovista, which has shown very promising result, again will be very good. Oral therapy has come. So various regimens are available, monthly, quarterly, pronto. One thing is very important is PRN should not be done from the beginning because this is the worst possible outcome. That is need basis. एक इंजेक्शन आज दिया, फिर आया नहीं है, फिर कभी भी दे दिया. That's not done. Regimen number 1 is that you keep monthly injections as we do Marina and Anchor. But this has tremendous burden on patients. He requires monthly visits, monthly injections, cost, risk of endophthalmitis. Regimen number 2 is that PIET study, this visual outcomes are inferior to the monthly injections, so it is not preferred. Regimen number 3 is that PRN, that you give the initial 3 injections, then follow the patient and give as when. So here you have to give 3 injections, and then based on disease activity you give. But there are problems of PRN that patient does require monthly visit to see the activity. This itself adds to the cost issues. Further problem of PRN is that you allow the fluid to accumulate and let it document clinically, then only you give. So there are periods when patient will be without VEGF inhibition. And then came the study of treat and extend. Here it was that you give 3 injections and keep giving injection till the patient is stable. And after the patient is stable, then you extend the interval by 2 weeks. So advantage here is that you do inject at that 6 weeks. You don't do those investigations, you do inject. So here the eye is without VEGF inhibition for less amount of time. So these results are better than PRN. Another regimen came which was fusion regimen. This is slightly confusing because here 3 injections, then PRN, then cessation of activity, and not long-term studies are available with the fusion regimen. So conclusion is, as of today, believe me, we can't cure this disease, ARMD. We can at best treat the manifestations, whatever you see, VC, CNVM or fluid on the OCT, we treat those. And all of us understand anti-VEGFs are the mainstay of management. And best regimen actually is monthly, if possible. Whether you give Avastin or Lucentis does not matter actually. But best regimen is to give monthly injections. Treat and extend is the second best option after this. So 3 injection monthly monitoring is the third best option as per my understanding. Only thing which should not be done is PRN from the beginning. So this is the crux of the whole talk which I had to share with you. And Lucentis, as to my knowledge, is the winner in this. Thank you very much for your kind attention.
Thanks a lot, Dr. Verma, for the practical guidelines. Dr. Azad on retinal vein occlusions, please.
Can I have my presentation? I think I must thank Palika for having given me this opportunity, but it's, and it's really very difficult to, put everything together in 7 minutes, but I'll try my best. Basically, I'll be talking about, the topic is macula in branch vein occlusion, so I didn't know what exactly she wants, but nevertheless, I thought it is better to update you about the different modalities of treatment in branch vein occlusion. I mean, not branch vein, but venous occlusion for that matter. I have no financial interest to be disclosed, and we all know that the majority of the vein occlusions are the branch vein occlusions, and one of the major cause of visual loss is macular edema. And with macular edema, we have a whole lot of events starting from the compression on the vein and then the blood flow turbulence is there, and then there is a pressure, and then there is a non-perfusion, and there's a hypoxia and VEGF, and then the macular edema. This we all know. The treatment options we have, earlier we used to have the natural history. We'll wait for 1/3 of the cases, they used to resolve on their own. Laser has been tried in branch vein occlusion. Intravitreal steroids have been also tried. Steroid implants now being tried very frequently, and some of us are also using as a primary mode of treatment. Anti-VEGF, of course, is everywhere, as just now we had heard in AMD and other diseases. And then combination therapy is something, which needs to be relooked. The main problem of the lasers were that there was a damage to the photoreceptors, and there was a decrease in the visual acuity, and also for cases where there was subfoveal macular edema because of branch vein occlusion. In these cases, it was very difficult to do the lasers, and therefore this emergence of alternate mode of therapies, intravitreal steroids. You have so many trials are there, and you have fanciful names from coming from the clinical trials like SCORE trial, which tells you that if you use between 1 milligram and 4 milligram steroids in cases of branch vein occlusion, you find a vision gain of 26% to 27% versus 29% as far as laser is concerned at 1 year. However, there was a significant cataract and rise in the intraocular pressure, and therefore this treatment is not very well accepted. And again, for CRVO, for the same thing, there was a higher chance of cataract and the intraocular pressure rise, and therefore not first line of treatment. If you see the steroid implants, which have been very often talked about, and we have been laying our hands on these steroid implants, you find that the vision gain in 0.35 and 0.7 milligram, especially in cases of BRVO, is 26% to 30% versus the sham. And in this particular case, we don't have the problem of cataract and the intraocular pressure rise, and therefore whatever rise is there is manageable, could be tried as a first line of management. And then central retinal vein occlusion, again, this 0.3 milligram is better than 0.7 milligram, and the concern for the cataract and the intraocular pressure is not there. That can be managed and perhaps could be used as a line of treatment. Now, anti-VEGF in retinal vein occlusion, these have been changed the whole concept of management of retinal vein occlusion, and we know that the benchmark in this particular area is the BRAVO study and the CRUISE study. And the BRAVO study says that 0.3 milligram or 0.5 milligram versus sham, we find that the 0.3 milligram is better, and where 0.5 milligram, 61% or 55%, and there's no side effects, and therefore this could be recommended as the first line of treatment. And then we have CRUISE study for central retinal vein occlusion, and we say that 0.3 versus 0.5, again, hardly any difference between the two, and at 6 months, and there are no side effects, could be one of the modality of treatment for this retinal vein occlusion and central retinal vein occlusion. If you see this branch vein occlusion, this is ILIA, and which is recently, I don't think it is available in India, and still not marketed here. 2 milligram was 4 weekly versus standard care, and you find there's a gain of 53% versus 27% at 6 months, and no side effects. And this also qualifies to be, in the line of first line of treatment for retinal vein occlusion, and perhaps the same thing for central retinal vein occlusion also, then could be perhaps recommended for first line of treatment. So you have a lot of alternatives, a lot of things available with us. The main concern is that the multiple injections have been recommended in BRAVO study, and we have to understand the branch vein occlusion especially. It is not a diabetic retinopathy or AMD, it's not a chronic disease. What is branch vein occlusion? It is an acute process, and this is an intraretinal disease. Branch vein occlusion is more forgiving, and it is less demanding for multiple injections. So that we have to keep in mind. So we did a small study, and we were trying to look for an efficacious, economical, sustainable, and acceptable management of branch vein occlusion, where we also took into consideration the compliance of our own community, that's the Asian countries, and also the cost factor which is involved in this. And what we did was, this is the study. You can see the 4 arms are there. What I have done is, because of paucity of time, I am not talking the entire study, but what I'm saying here is that we have superimposed our study over the Bravo study. Although the study protocol were not same, nevertheless the end point of the result I'm trying to show you here. As you can see here, the top one is the one with the laser with Lucentis, which means after one Lucentis, we gave the laser and we followed these patients PRN. And the other one is laser plus loading, which means 3 loading dose of anti-VEGF, especially Lucentis we had given. And then after first injection, we did the laser and then 2 more Lucentis, and then we did the PRN. And if you see here the Bravo and the sham, in the Bravo study, Lucentis and sham, you find that the results were much better in these 2 groups where laser loading means 3 Lucentis and 1 laser was done. And then the other group where 1 Lucentis was given and laser and followed PRN. So that's what we want to show you here. And the other study we did, we compared the Avastin with the, this is the mean change from baseline. Oh, this is the central foveal thickness, what I'm talking here. And again in central foveal thickness also we found that the results were better when we give 1 injection plus laser or 3 injections plus laser rather than giving monthly injections of Lucentis. And this is the economics. I will not go into the detail now with the Lucentis coming, bringing the price down. Of course, this has gone much less, but nevertheless, still Avastin, is less costly as compared to the Lucentis. And also, Bravo study will cost you more as compared to what the study we did. There's another study we did between ranibizumab and bevacizumab. As you find here, the 2-line and 3-line improvement was not much difference between the ranibizumab and the bevacizumab. Of course, little bit edge of Lucentis as far as the 2 modalities are concerned. If you see here, if you see the summary, BRVO, in BRVO, laser, steroid, anti-VEGF, steroid implant, and this idea, you find that anti-VEGF has definitely better than compared to others. Visual benefit in terms of visual benefit. And in CRVO also, you find here that the anti-VEGF is scores very close to this idea, which is 55 to 60%. So they are almost, competing with each other. So my take will be first line is anti-VEGF or a steroid implant. Alternate will be steroid implant. Combination therapy is efficacious, economical, sustainable, and acceptable. As I told you, that you give 1 injection, especially for rectal vein, this branch vein occlusion. You give 1 injection of Lucentis and then do the laser and follow it PRN. So that is, that can be tried. And of course, laser and intravitreal Tamsin alone has minimum or very little role to play in rectal vein occlusion. I think that was the last slide. Thank you very much.
Any questions of Dr. Azad?
And you will give the lectures after the questions after the lecture.
There's one question, there are no 2 questions.
What does he mean by laser? Is macular laser or?
So when you see a patient of BRVO, your first choice is Ozurdex or
No, my first choice is I use
anti-VEGF.
and then do the laser.
How long later would you do this?
Say after 7 to 10 days.
Okay, so where's the folder? Which was treated with, these are the early phase and late phase, treated with, initially not treated, and you see over 10 months there was no resolution, and then within a month of treatment there was a resolution. She refused PDT because of the cost issues, but after a few months she again came back with a new leak. Again this was treated. So this patient has been treated in both eyes many times and she resolves every time. This is another patient who has a subfoveal leak, and this is symptoms over 6 months, treated with photodynamic therapy and with good resolution. Sometimes even the acute CSCRs can be very atypical. This does not look like CSCR, And the history is also not very old. He is very clear that it is not old, and there is an exudative material. Unlike the clear fluid we see, there is an inferior retinal detachment, but the angiogram confirms that it is indeed only CSCR, and laser has resolved the lesion within 4 weeks. But what is really my point to express here is the chronic cases which come with bilateral extensive progressive RP atrophy. These are very old patients, usually above the age of 55. They are usually males, bilateral, very poor vision, usually associated with bullous retinal detachments. And the problem is these can be confused with choroiditis or VKH with bullous RD and RP changes. And if you by chance give steroids, either orally or intravitreal, then you worsen the condition quite significantly. And they may have cystoid retinal degeneration. The angiogram is very, very distinctive, very extensive RP atrophy, decompensation with extensive leaks, gravitational tracts, and the response to treatment is generally very poor. So they have these kind of degenerations of the retina in both eyes, and generally worsens with time if not treated, or even if treated. The treatment modalities, the treatment of first choice is photodynamic therapy, could be reduced fluence or full fluence. Second choice could be anti-VEGF therapy. Focal laser usually does not work for chronic CSCRs. So these are just to show a few cases. This is a patient, elderly male, with several months loss of vision, bilateral. He could not afford PDT, so we did an angio and treated him with laser, and we found that there was resolution of the subretinal fluid and vision improved. But a few months later, he came back with reappearance, and now we did do PDT, and you see that this was done in 2012, and he's quite good even now. This is another gentleman with bilateral extensive RP atrophy decompensation. We treated him with Avastin, and there was worsening, and you see by now there was much worse leakage throughout the posterior pole. And now we treated him with PDT, which was standard fluence, but no response. In the right eye there was a response, left eye no response, but even the right eye after some time started recurring. So this patient did not respond to PDT. This is to show how Avastin can work in some of these cases. Extensive RP atrophy, CSR with an indefinite kind of leak, which we did not think we could laser adequately. So you see a single injection, and he is good since 2012, now 2 years. Another patient with CSCR, subfoveal leak, could not afford PDT. We gave Avastin, and there is this inadequate response. There is a response, but he hasn't dried out completely, and he hasn't come after that, so we don't know. But it's known that Avastin may give a suboptimal response, a slow, fluctuating response with recurrences. Sometimes we can get away. This patient has a long history, is 8 months, and with this juxtafoveal leak, we treated with laser, and we got a good response. So these are the other options given for chronic CSCR. It has been tried and found successful. Aspirin, because it has an antiplatelet effect, rifampin, beta blockers, but these are all anecdotal and no controlled studies are available. So to conclude, atypical chronic CSCR is a potentially blinding condition. Response to therapy is generally poor, and the best line of treatment is photodynamic therapy, but even that gives variable results. I think we have overshot our time. How many people do want to listen to photodynamic therapy in CSCR, in macular exudative disorders? Hands up. PDT. Okay, so the next session, people are here. Can we take a couple of minutes?
We are losing audience.
Okay. All right, we'll call it a day. Thank you to my co-speakers, Dr. Azad, Dr. Talwar, Rajiv, Parveen Sen, and Anand. And thank you to the delegates.
Anyone who wants to stay for genetics, it's valuable. So stay, we have handouts, and you don't have to move, it starts right away. So stay, sit. On the research level, in genetics. Chita Kanabriyan from LV Prasad, and does the same thing, a lot of research in molecular genetics. Dr. Natarajan, who was an excellent speaker, he will be with us a little bit later. He'll talk on retinitis pigmentosa. macular dystrophy and diabetic retinopathy, and Sharola Damaraj, who goes between Moorfields Eye Hospital in London and Mangalore, where she does research too on ophthalmos Tay-Sachs and Leber congenital amaurosis. So you're in for an excellent panel of the best qualified American and Indian researchers in genetics. So hold on to your belts, here we go. Originally, genetics was limited to the esoteric publications of ORVO and ophthalmic genetics. However, I would say the general publications in ophthalmology and in other fields became interested in genetics and have highlighted it on their front pages. Here's the archives, and here's the Academy's issue of ophthalmology. Even the lay press has become interested in genetics. Newsweek, Time magazine. So as a result, we as physicians have to know genetics. Our patients know it, so we've got to catch up with them, because they're the ones asking us the questions. A lot has occurred. In the Asian Games and the World Games, it was a question of what sex the players were, the winners. So what they did were testings. Notice the 46 for the number of chromosomes. But why pull down their pants when all you have to do is check their genes? And it gets a little complicated. We all know that the genes for maleness is on the Y chromosome, right on top, on the X chromosome here, which is not neutralized at all by the Y, which is much shorter. This is the area for maleness. And here's the Y chromosome. And if we get an exchange, it doesn't matter that much if it stays in the same body. But if it does change over and there's no counterpart, then the female will have the SRY gene and therefore have male characteristics. And here is the opposite with the male without the SRY gene. So even genetic analysis is not the answer. And even if everyone has all their chromosomes in the right place, there are other factors that could interfere with that. The adrenal glands producing too much testosterone, and so therefore it makes a female very masculine. So it's very confusing. And recently, in the newspapers, it gets even more confusing because we can see that if there are two in the mitochondria, in the rat retina, and I'll show you in the cornea, 2 X chromosomes, one of them will be suppressed. Sometimes there's a mixture. In some cells, from the male, it will be suppressed. In other cells, from the female, it will be suppressed. So you have this battle going on within the women. And it shows up. Maybe I won't go into it, but I think this is one of the reasons why females differ from males. Because look at this battle. One is from the male, one is from the female. And here's the cornea. You can see the mixture in the corneal cells from the female X and the male X. So it gets very confusing. And here's the original article in Neuron. It just came out in January. People are interested in heredity. Am I going to pass on this? Am I going to pass on that to my offspring? What's going to happen to me in the future? Well, Time magazine wrote about it 2 years ago, and for decoding disease. And this is the complexity that they have. You can pick it up from Time magazine. All the areas that could be inherited. And recently, there's an article in Science Times in December of last year about the commercial aspects of having your genome analyzed. And there are companies out there. But turns out if you send your tissue to different companies, you'll get different results, different heredity patterns, different opinions. So much so that 23andMe had to shut down their genetic test They were shut down by the U.S. Food and Drug Administration. We know about what happened with bin Laden and how they checked his genes. The reason I'm showing you this, even though this was a couple of years ago, was that here in the lay press, it talks about DNA sequences and all that, 13 to 16 spots, tandem repeats. So this is what the people are reading. And right over here, it talks about short tandem repeats. Your patients are learning about it, and you've got to know it too. And this is the genome-wide association study, GYAS. We hope to pinpoint the changes in common disease, but it is disappointing because many of the diseases are not from just one gene, but the polygenic. And here we have certain disease, Leber's congenital amaurosis. Look at all the different genes that interact, and some of these genes can actually cause other dystrophies. And proteomics, it's the same thing. Catalog of the proteins in the cell, specified by the genome, making it even more complex. By the way, a lot of this is in your handouts. In the back, you'll see a glossary of terms, and you'll be able to know as much as your patients. Well, you might touch on pre-implantation genetic diagnosis and in vitro fertilization. And, of course, we're worried about new viruses being made genetically. And, of course, I mentioned that genetic testing hopefully could predict a medical condition. Maybe we could have certain drugs specified for a certain patient, while another person with the same disease may not react to those drugs. And that's molecular therapeutics to reach a point of knowledge of a patient's genetics so that the medication can be pinpointed. So, having introduced that and hopefully stimulated your desire to learn about genetics, I'll give you the crash course. It turns out there's only about 1 to 5% of the base pairs in the exons that code for proteins. The rest is called junk, but it really isn't junk. As a matter of fact, the New York Times said it isn't junk because it's used for hereditary issues, for family linkage. Now look, this is good. Differences in the genome from one person to the other is only about 0.1%. And over here, I want to just point this out. A unit of measurement, a centimorgan, about 1 million base pairs. It's used for measurement. So whole morgan means that for every meiosis, there will be a crossover. And you'll see that in a minute. But here the usual unit is a centimorgan, so it only occurs that crossover 1 out of 100 meiosis. Here we have the crossovers taking place. And so therefore, the daughter cells in meiosis aren't pure from, let's say, the mother on one side, the father on the other side, but it's a mishmash, a mixture of both on each chromatid. Then we have it even more complicated, where we could get different chromosomes crossing over. Here's a mixture of 4 and 20. Nothing's easy. Anyway, when we talk about genetics, the center is the centromere, the bands go up in order, the numbers get higher, and on the Q, the longer, again, from the center down to the telomere, the numbers go higher. And here's the spread. We can see that the chromosomes get smaller and smaller and smaller, except that 22 is a little bit bigger than 21, X and Y. All these are wrapped up in histones, which are proteins, and all the histones are wrapped up like this, and then it's stuffed into your nucleus. Can you imagine? It is. Mitochondria. This is an important issue that's really of recent interest, because, number one, your heredity is from your mother, not from your father. So any of the diseases which you'll see that are limited to mitochondria, you can blame your mother for. Anyway, mitochondria have to do with the energy, Krebs cycle, and also cell death. And here, the DNA is in a circle, and you could have a lot of mitochondrial DNA, each one sort of different, so you get a mosaic pattern. And of the number of genes, only 37 in the mitochondria, and only 13 code for proteins. Look at this. Ophthalmology has 3 of them: Leber's hereditary optic neuropathy, external ophthalmoplegia, chronic progressive external ophthalmoplegia, and Kern-Serre disease. Do you know that 90% of the genes that are express themselves in the tissue and cells of the eyes? I mean, the eye is a fantastic media for that, because any alteration, it's noticeable in the vision. So it doesn't take much for the vision to be affected. And that's why it's a good area for study. It's easily accessible. You can see it. Now here's the mitochondria inside the cell, in the ribosomes, and all this take place. This is sort of a repeat. There are about 2 to 10 mitochondria in each of the cells, and many of these came from bacteria and ultimately became part of the nucleus. And here's the Krebs cycle in the mitochondria, and with fusion and fission creating the energy. All this is in your handouts, plus if you want to read more, the references also. And it even gets better. Let's say that there's a concern that a family has mitochondrial disease from the mother. So what do? They take the nucleus from the father, take a nucleus from the mother, in other words, the sperm from the father, nucleus from the mother's ovum. They then take it into another ovum from another woman who you know has good mitochondria and replace it. So here we have the outer mitochondria from a third person, the sperm, the egg nucleus from the parents, and if you want to, you could have it IVF'd into a third woman. So here's a child that could have 3 mothers. You talk about confusion? Okay, the breakdown. Everything is based upon 2 purines and 2 pyrimidines. That's the basis of all life, whether it's a leaf or whether it's a human. And we have deoxyribonucleotides and ribonucleotides all attaching to the pentose C2 and the base. The base is on C1 and the phosphate C5. And here, this will be in your handouts. I'm not going to spend time on this. And here's the genetic pattern. We can see the male and female, and how it's passed on to generations. We go, this is the first, second, and third. And here is the person who introduced itself to the practice. And so it's marked accordingly, and those that are affected. This came from a study that Dr. Aldavi and I did on cornea plana. And this is very interesting because that the mother has 2 partners, both of which produced children that had the cornea plana. But she has a third partner, and that one child doesn't have it. And we lost track of the fathers. They're in jail. Here's the purines. Notice that they're color-coded, and this is very important for the PCR tests. Polymerase chain reactions, that's being done in Dr. Aldavi's lab, and I'll just briefly show this. Here we can see how the purines and pyrimides hooked up with the proline, and here, open reading frame, I think they're throwing me out, of how to read this from the second letter. All this, these are the amino acids, and we can see there are 20 amino acids, and each one can have various combinations of the bases. We have the start, the methionine, and we have the end, the stop codons. And here's the exons with the transcriptions into RNA, and we have the translation into amino acids, and again how you read it, and I won't go into this slide. And again, the open reading frame shift is when another, you can have a base inserted or deleted, and it throws the whole reading off, and then you get a stop coding. If you have a missense, it's a change of 1 amino acid. And here's some associated genetic diseases when you have an elimination or a deletion. It's called nonsense. I won't go into this, But here's the article on genomics on the eye from the New England Journal of Medicine. The reference is in your handouts. Promoters and enhancers and silencers are all part of it. This is the encyclopedia of DNA elements that being referred to, and epigenetics is the study of hereditary changes other than evolution, which would be Darwin and the draft. So I want to quickly go into, this is where the methylene tag is affected by environment, and that's epigenetics, and this is how the PCRs are done, the sequences, where we can see that one of the bases is changed for another because the color coding changes. Now it gets even more sophisticated, the chips and newer technologies, and we can see as a result to check the genome, this is the cost involved. Now it's just over $5,000–6,000. Molecular therapeutics involve the blastocyst, where you could take some tissue, parthenogenic if it's just from the mother, and you could grow stem cells. You could even induce it from the skin, from fibroblasts. And this is a corneal orb that was put together, a combination from Sankara Nathralya, Dr. Krishna Kumar, and stem cell genetics in California. And here's the induced stem cells, transcription factors, where you can change from the skin fibrocysts into whatever tissue you want. And we could even produce the retina and part of the eye. For those that are more interested in this, there will be a course given in a couple of weeks here in India. Here's my references, and you can see that here we certainly are off to the future. Thank you. I'll now introduce Dr. Aldavi, who will talk about the cornea. It's a fantastic lecture. You're fortunate to have him with us.
Thank you, Jerry. Can we have the lights up a little bit so I can see where this connection should go? We have the lights up. I can do it as long as you can turn the lights on for me. Can we turn the lights up a little bit? And I thank them for that funding. This was a paper that we published in the journal Ophthalmology last year. Ed Stone was the driving force behind this. It was a task force put together by the American Academy of Ophthalmology, we've got a loose connection here, in which we talked about the utility of genetic testing in the clinic. And really the punchline of this was that for conditions such as complex disorders, we recommended against routine clinical testing, but that for Mendelian disorders, such as most of the corneal dystrophies, what I'm interested in, that certainly genetic testing does play an important role and can help a clinician to either confirm or refute presumptive clinical diagnoses. This is going to continue to do this. Let's change to the other podia, if we could. I think your VGA cable is a little bit loose. So if you give me a moment, I'm going to change to the other podium. Again, if you get more interested in this, I would recommend reviewing this article, even though I wrote it. It's well written, in which we reviewed what's known about the genetic basis of the corneal endothelial disorders, and I think made some critical comments in here and supported them, though, such as there is no such thing as autosomal dominant shed. It does not exist. There's only 5 families in world literature, and we went through each of those families one by one and showed clearly that those either have posterior polymorphous corneal dystrophy, are actually recessively inherited, or in one family, that's actually the family that was used subsequently to identify genetic basis of congenital hereditary stromal dystrophy. So I recommend reviewing this if you're interested. And many of you who see patients with inherited disorders may say, well, is genetic testing really required? I can tell if something, for example, is a corneal dystrophy by taking a family history, looking at other members of the family. And since most of these are autosomal dominantly inherited, there will be a parent who is affected. But I'd put it to you that neither reliance upon characteristic clinical features nor a family history are reliable means of diagnosing corneal dystrophies, the only real definitive way to diagnose dystrophy is with genetic testing. And to make that point, I'm going to show you a couple of cases here. The first one is a 49-year-old gentleman who presented to me about 2 years ago with fully progressive decrease in vision over the previous several years. His past ocular history was significant for corneal opacities diagnosed in each eye 6 years prior to presentation. So he's in his early to mid-40s when he was first noted to have corneal opacification. No family history of poor vision or corneal transplantation. So on examination, you can see a sort of looks like salt granules here located in the deep corneal stroma. This was symmetric between the two eyes. And you see these opacities were fairly diffuse. You see in the slit beam here, and also in this thinner beam here as well. You can see these opacities located in the posterior stroma. These are not guttags. This is not endothelial. These are deep stromal. Does anybody have any idea what this could be? Anybody here a corneal specialist? Raise your hand if you are. Okay, nobody's fessing up to being a corneal specialist. Okay, fair enough. So this is one of the few times I asked a patient to take off their pants in my clinic. Probably the only time I asked them to take off their pants. And this is what I saw. This is the gentleman's thigh. You can see here these sort of unusual lines on the skin. Picture the patient's knee and shins. Anybody have any idea what the diagnosis is? Okay. And here's his feet. So I had an idea of what I thought the diagnosis might be, but I wasn't sure about it. So we collected blood for analysis. In this case, we're looking at a pedigree. The proband that we just saw pictures of is this individual. We're looking at the family history of skin abnormalities. So he and a number of other family members had similar skin changes, although he did not know, as I said on the previous slide, of anybody who had any visual complaints or history of corneal transplantation. What we did was copy number variant analysis. And this is available at UCLA in a research lab, but it's also available in other laboratories across the United States, I'm sure here in India as well. It's a way of looking for chromosomal deletions or additions. So you're looking at changes in the chromosomal complement. And it will show you, for example, you see this red line here. This chromosome says that that means that there's a loss of material. Blue means there's a duplication of material. Here on the X chromosome, we saw that there was a loss of material near the tip of the P arm. And here we're looking at a higher magnification view. This is a portion of the X chromosome, as you see here, the base pair position located below. You'll see if this patient is male, of course, he's going to have one copy of each gene on the X chromosome. So normal complement would be indicated by red lines at this level. But you notice in this section that there's a deletion. So there's loss of genetic material. And in that region of the deletion, we see the STS gene. And mutations in or deletion of the STS gene has been associated with X-linked ichthyosis. And that's, in fact, gentlemen, in the back of the room, if you could stop talking or go outside, please. So in this case, this was a deletion of the STS gene that led to X-linked ichthyosis. This patient actually has said that his skin condition has never been diagnosed previously. So in this case, it was an ophthalmologist using genetic testing who diagnosed this skin condition and the associated corneal changes. We published this paper, this report in Cornea a few months ago. Second case, this is a 30-year-old woman who was interested in LASIK surgery who presented to a outside ophthalmologist for refractive surgery evaluation. She had a history of wearing glasses and contact lenses for correction of moderate myopia and astigmatism. She is adopted, so did not know family history and is not in contact with her biologic parents. So on examination, she had a few small opacities in each cornea. They were not visually significant. This patient's corrected vision was 20/15 in each eye. Here we see the other eye. Again, small opacity here in the slit beam, but the patient's vision was fine, had no problems with photophobia or glare. So there's another view here, just a sole deposit. You can imagine that if you did a quick examination prior to refractive surgery, you could miss this very small deposit. It's actually hard to photograph. So the patient had LASIK surgery performed in each eye, and then a year later had an enhancement performed. She ended up doing well after surgery, regaining 6/6 vision in each eye. But then 4 years later, she noted decreasing vision in each eye and returned to the ophthalmologist's office. And so for those of you who are retinal specialists in the room, not used to looking at the cornea, all this stuff is not normal. So dense central stromal opacification in each eye. We see here in retroillumination. A high-resolution anterior segment OCT. Here looking at the patient, we see very clearly that there's this linear deposit of this hyperreflective material corresponding, of course, to the LASIK flap interface where these deposits were located. That's not the only case. I've seen about 5 cases. My colleague E.K. Kim in South Korea has reported, I think, about 30 or 40 cases, although he's told me he's seen about 200 patients with this phenomenon occur. So this is a patient who had nothing in the cornea. I know the surgeon who did this surgery in San Francisco. This is a year after surgery. The patient developed acceleration of these deposits. Again, he had no deposits prior to surgery. And you see in the thin slit beam that these deposits are located in the region of the LASIK flap, as we saw in the first patient. Here's another patient who had LASIK surgery. This patient had, the surgeon told me, a few small deposits in each cornea, similar to the first case I presented. And then this is, again, a year after surgery with dense stromal deposition. Here we see on higher magnification view. This patient's vision dropped down to the level of 660. And the patient required bilateral penetrating keratoplasties. So if you do this in the United States, if you do LASIK surgery on a patient with this condition, you'll certainly end up in a court of law. And the same may be true here in India. Histopath was obtained on the patient with the bilateral penetrating keratoplasties. We see a deposit here. We see, again, this lamellar deposition of the dystrophic material corresponding to the location of the LASIK flap interface. I obtained blood from each of these patients and did screening of the TGF-beta gene. We're looking here at exon 4. Dr. Schultz showed us sort of how to read some of these chromatograms. Remember, 3 nucleotides encode for an amino acid. This is the wild type or normal sequence. And in each of these patients, we saw nucleotide change that caused an amino acid substitution. And this is the classic amino acid substitution associated with combined granulomatous corneal dystrophy, also known as Avellino corneal dystrophy. So each of these patients has Avellino corneal dystrophy. The reason why this occurs with this dystrophy and not the other dystrophies associated with mutations in this TGF-beta gene is that this has a later onset of the affected phenotype. So somebody can be 25 years old or 30 years old, go to LASIK surgeon for surgery, have this condition, and either this deposits not be seen, there be no deposits, or very subtle changes the LASIK surgeon may miss. They have LASIK surgery, that you saw from the pictures, a year later require corneal transplantation. So I would put to you that anybody in this room who does refractive surgery should have a question on their patient questionnaire regarding a family history of inherited corneal disorder or corneal transplantation. And if they answer yes, you need to ask them further, what was the reason for a corneal transplant, what sort of condition they have, and if they are not able to provide you an answer, or if they say it's this some dystrophy, I don't know what it is, but they require a corneal transplant, you must do genetic testing for that patient. If you don't, you end up missing this condition, you will end up having to do transplants or send that patient for corneal transplants. You'll probably also end up in a court of law. Because this combined granulomatous corneal dystrophy is the most common corneal dystrophy in Korea, 1 out of every 875 individuals has this. LASIK surgeons in Korea, most of them are routinely doing screening of this TGF-beta gene prior to LASIK surgery. And there's a company called Avellino now that is providing this service for surgeons in Korea and trying to break in the United States market as well, trying to convince surgeons in our country to consider doing this prior to LASIK surgery. The problem is that this condition is not as common in the United States as it is in Korea. So I really don't think that this needs to be performed routinely in our country, although it certainly does make sense in Korea where this is more common. I have ordered this for a few of my patients, and you see here this is a patient whom I sent the blood off just a few months ago. The result comes back in a very easy-to-read format like this. In this case, the patient, in fact, was heterozygous, meaning they did have one mutant allele for the TGF-beta dystrophy known as Avellino or combined granulomatous corneal dystrophy. So clinical testing for inherited disorders is now with us in the United States. It certainly makes sense in some countries like Korea and Japan where these conditions are quite common. I don't think this condition is that common here in Korea or in India, as far as I know. But there probably are conditions here in India that are common enough that clinical testing does make sense. So that takes us to the question of, well, if I want to, on occasion, order genetic testing for a patient of mine, how do I go about it? How do I find a lab that performs genetic testing for inherited ocular disorders? If I do this, do I need to get the patient's consent? what's involved in collecting a DNA specimen and sending it off to the laboratory, and most importantly, who's paying for this? The patient, the doctor, insurance company, or somebody else? Well, one option is to send that blood sample or buccal saliva sample to a research lab, such as the one that we have at the Jules Stein Institute. There's lots of big academic centers here, for example, at Erevin, that are doing this testing for research basis. These are usually university-based laboratories, research laboratories are, where genetic testing is performed underneath an IRB-approved protocol. So in this case, patient consent is required because this is considered research. The costs associated with genetic testing are typically paid for by research funding. So that's nice that you as a referring physician doesn't usually have to pay for genetic testing when it's being sent to a research laboratory. The genetic testing can be geared towards first looking for previously identified mutations, and if none are found, then looking for novel mutations in the gene. However, a research lab is not able to provide validation of results. So if a research lab gives a result back, you cannot use that result in making clinical decisions. You have to have that result confirmed by a certified laboratory. And these are called diagnostic laboratories. They can either be in a university setting or in private industry. In the United States, they're certified by accreditation body. I assume the same is here in India. In this case, you're ordering this as a test, just like a complete blood count, like a chest X-ray, like a serum or a serum test for, say, a prostate cancer antigen. So you don't need to get patient consent necessarily. Patient counseling, however, as far as genetic counseling, should be provided to the patient both before and after testing is performed. The costs associated with specimen collection, transportation, and mutation screening are paid for either by the patient, the requesting physician, or by a third party. And since it is a diagnostics laboratory that is validated, they are able to provide confirmation of the results. In the United States, one of the laboratories that meets these criteria is the Carver Laboratory located at the University of Iowa. They do take samples sent in from other countries as well, so this is an option for you here in India. They do genetic testing for the TGF-beta dystrophy, so lattice, granular, combined granulitis, etc. Probably a better option, though, for you here in India. A lab that tests for more conditions is ASPR. They are located in Estonia. They will look for genes, mutations in a number of genes associated with inherited corneal disorders. You kind of have to know what you're looking for, though, when you send them a sample. For example, they have something called the APEX-based test, in which case they'll screen for 333 mutations in 13 different genes, which are listed here. So, if you have a patient you suspect may have lattice corneal dystrophy, but there's no family history, so you're concerned that this could be a myeloproliferative process associated with corneal amyloid deposition. Well, in that case, you're looking for a mutation that's highly conserved, and lattice is usually the same mutation in the TGF-beta gene. So in that case, it makes sense to ask for this test. However, if you're looking for, let's say, a patient you think may have macular corneal dystrophy, which you see a lot of in southern India, in that case, each family tends to have a unique mutation. So screening for the previously identified mutations will likely not confirm the diagnosis. In that case, you're probably going to need to order what's called next-generation sequencing, where they sequence the entire gene. The same is true for the posterior polymorphous corneal dystrophy. The mutations associated with that are unique to each family. This is more expensive, so you really have to have some a priori knowledge of which condition you think the patient has in order to order the appropriate test. I want to thank those folks in my lab who have helped me along the way with some of the publications that I mentioned there. You see them listed there and their pictures. And I thank you for your attention.
Well, Dr. How do you see it? Does anyone have any questions? This is the time to get them. Okay, we'll go on to the next speaker, Dr.